Yes.
Yes, ma'am.
Okay, we'll start then. We have 90. Okay, we'll start then. Okay. Okay, so we'll be covering the management part of the heart failure and we'll be covering shock as well. Okay, so starting with the management part. Okay, so management of heart failure, it is divided into management of acute left heart failure and management of chronic heart failure. Okay, so whenever we are talking about this management of heart failure, we are mainly focusing on the left heart failure. Okay, so management of acute left heart failure. Okay, acute heart failure. So this acute heart failure resulting in pulmonary edema. Okay, it is the medical emergency and it should be urgently treated. Okay, so whenever the patient comes, the patient should be asked to rest. Okay, and continuous monitoring of the ECG, blood pressure. Okay, saturation, it has to be done. Okay. So immediately after the patient enters the emergency room or the ICU, so this intravenous opiates can be given, which helps in decreasing the distress in these patients. Okay, but it should be used very cautiously because it may cause respiratory depression and it may cause exacerbation of hypoxemia and hypercapnia. Okay, so just summary of the management of acute pulmonary edema. Okay, so you have to ask the patient to sit up, you have to give high oxygen flow through the mask. Okay, and nitrates, it's generally given to reduce the preload and the afterload. We can give it in the IV route, that is glycerol trinitrate. Okay, and it can be given in the buccal dose as well. Okay, so 2.2 to 5 mg buccal dose can also be given. And if the patient has fluid overload, there is role of furosemide as well. Okay, so this is for the acute left heart failure. And sometimes if the patient does not have blood pressure, okay, the patient is hypertensive, or if there is any evidence of low cardiac output, okay, so there may be role of dobutamine as well. Okay, so if the measures improve ineffective with those medications, okay, inotropic agents like dobutamine, it has to be given, which augments the cardiac output mainly in hypertensive patient. Okay, so this is regarding acute pulmonary edema. Okay, so we'll be discussing about this again when we are talking about cardiogenic shock. Okay, but I'm focusing more on management of chronic heart failure. Okay, so management of chronic heart failure, it is divided into different subheadings. We have to consider the general measures, prevention of the precipitating factors, medical management of the heart failure, prevention of the complications that may occur, management of complications, and cardiac interventions. Okay, so firstly, general measures. Okay, so this is for the chronic heart failure. Okay, so all the patient with structural heart disease, their therapy depends on NYHA functional class. Now, I think all of you know what is NYHA functional class. What is the full form? Any one of you, can you answer? NYHA? What is the full form of NYHA?
New York Heart Association.
So how many classes are there? How
Four
many?
classes.
4 classes. Okay. So as I've said, okay, so this is important for management as well as for the bedside. Okay, so yesterday I showed you the classes. Now this is the more elaborated form of the same NYHA functional class. Okay, so class 1, okay, I'm repeating it again. Okay, so class 1 includes all the patient with cardiac disease but without resulting limitation of the physical activity. The patient has cardiac disease, but there is no limitation of the physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea, and angina. Okay, so they do not have any limitation of no limitation of physical activity. Ordinary physical activity does not cause symptoms. Okay, class 2 includes all the patient with cardiac disease resulting in slight limitation of the physical activity. Okay, so slight limitation of physical activity. Ordinary physical activity results in fatigue, palpitation, dyspnea, or anginal pain, and they are comfortable at rest. Okay, so these are the patients who are under class 2. And class 3 includes all the patients who have cardiac disease and have marked limitation of the physical activity. Marked limitation of the physical activity, but they are comfortable at rest, but less than ordinary activity causes fatigue, palpitation, dyspnea, or anginal pain. Okay, so the class 4 includes all the patients with cardiac disease resulting in inability to carry out any physical activity without discomfort. Okay, so symptoms of heart failure or anginal symptoms may be present even at rest, and any physical activity is undertaken. If undertaken, discomfort is increased. Okay, so this is elaborated form of neuro heart classification. Okay, so you can just say no limitation, slight limitation, marked limitation, symptoms even at rest. And you have to know what are the symptoms the patient may have. Okay, fatigue, palpitation, dyspnea, and anginal pain. Okay, so first of all, you classify the patient according to NYHA functional class. Okay, so if the patient is in NYHA functional class 1, that is asymptomatic left ventricular dysfunction, the target of the management, okay, it is just to slow down the process of this cardiac failure by blocking the neurohormonal system. Okay, so this is to prevent the cardiac remodeling. Okay, so if the patient is in NYHA functional class, then it is just to slow down the disease process by blocking the neurohormonal system. Now, what are the drugs that can be given to block this neurohormonal system? So ACE inhibitors and ARBs. Okay, so ACE inhibitors and ARBs are the drugs that has to be given to a patient, even if the patient is in NYHA functional class 1. Now, if the patient, they are in NYHA functional class 2 to 4, okay, so the aim of the therapy is to limit fluid retention, lessen disability, and reduce the risk of further disease progression and death. Okay, so the goal is generally achieved by use of diuretics to control salt and water retention, and neurohormonal intervention to minimize the cardiac remodeling by use of ACE inhibitors, ARBs, and even beta blockers. Okay, so what are the things you have to consider in general measures? Okay, so general measures, it mainly aims to screen for and treat comorbid conditions. Okay, so comorbid conditions can be hypertension, coronary artery disease, diabetes, anemia, sleep disorder, breathing. So are the conditions, these are the comorbid conditions which may exacerbate heart failure. So it is first indicated to screen and treat these conditions. You have to ask the patient to stop smoking, okay, and limit alcohol consumption. Okay, so in general, we ask the patient to limit alcohol consumption, but in certain conditions, like if the heart failure, it is because of alcoholic cardiomyopathy. Okay, you have to ask the patient for complete abstinence. Okay, and avoid extremes of temperature and heavy physical activity. Okay, so you have to be very careful with the use of certain drugs, okay, which may worsen heart failure. This should be avoided, mainly NSAIDs. Okay, and patients should receive immunization with influenza and pneumococcal vaccine to prevent recurrent respiratory infection, because again, respiratory infection, it may exacerbate heart failure. Now, what should be the activity of the patient? Okay, so heavy physical labor is not recommended in heart failure, but routine modest exercise has been shown to be beneficial in patients who have NYHA function 1 to 3. Now, regarding the diet, okay, so sodium restriction to around 2 to 3 grams per day. Further restriction is required if the patient has moderate to severe heart failure. Fluid restriction is unnecessary unless the patient develops hyponatremia with sodium level of less than 130 milliequivalent per liter. And if the patient has cardiac cachexia, okay, there is role for caloric supplementations as well. Okay, it is generally in patient who has advanced heart failure and unintentional weight loss or muscle wasting. Okay, so this is just the summary of all the things we have discussed. Okay, education, explanation about the nature of the disease. Okay, treatment and self-help strategies. Okay, some of the patient, they tend to have exacerbation because with treatment they tend to get improvement in the symptoms. They tend to decrease the dose by themselves. Okay, you have to educate the patient regarding the need for continuation of medication. Diet, good general nutrition and weight reduction for obese patient, and avoidance of high salt food and added salt, especially for patient with congestive heart failure. And alcohol, moderation or limitation of alcohol consumption, and in cases of alcohol induced cardiomyopathy, there should be complete abstinence. Smoking cessation should be encouraged, and regular moderate anaerobic exercise should be advised for a patient who are in NYHA functional class 1 to 3. And as we have said, vaccination, okay, influenza vaccination, pneumococcal vaccination, they are recommended for all the patients to prevent recurrent respiratory infections. Okay, so now we'll be going to the medical management. Okay, so this is the algorithm for the treatment of congestive heart failure. Okay, first of all, you diagnose heart failure. Okay, then the second step you should assess is assess for the fluid retention, whether the patient has fluid retention or not. You see for the dependent edema, that may be pedal edema, sacral edema. Okay, you see for the presence of ascites. Okay, you see for the rate JBP. Okay, so if the patient has fluid retention, the first drug that should be prescribed to these patients is diuretics. Okay, and as we have said, to all the patient who has heart failure, even if they have fluid retention or not, the first drug is generally given for the control of neurohormonal activation. Okay, so ACE inhibitors or ARBs. ACE inhibitors are given first, but if it is intolerant, then ARBs are the drug that is kept in the option. Okay, the other drug that has to be added if the patient still remains symptomatic is beta blockers. Now, if the patient still persists to have symptoms, then there will be role of angiotensin receptor blockers and angiotensin antagonist, this hydrolazine and nitrates combination, digoxin. Okay, so if they persist to have symptoms, then these are the medication that has to be added. And if the patient still had symptoms, then there may be role of intercardiac device or cardiac resynchronization therapy. Okay, so these are the intervention that can be done to a patient who has uh, chronic heart failure, congestive heart failure. Okay, so drugs that can be used: diuretics, furosemide, torsemide, hydrochlorothiazide, metolazone. Okay, angiotensin converting enzymes inhibitor, ACE inhibitors, enalapril, captopril, lisinopril, ramipril, angiotensin receptor blockers, losartan, telmisartan, valsartan, irbesartan, okay, beta blockers, carvedilol, bisoprolol, and metoprolol. Okay, so other drugs that can be used, as we've said, if it's not improved with all the first line drugs, okay, the other drugs to be added are spironolactone and eplerenone. These are the potassium sparing diuretics, okay, digoxin, and fixed dose combination of hydralazine and isosorbide dinitrate. Okay, so going to the individual drugs, okay. So diuretics, they are used to control the fluid retention in advanced heart failure. And it is also used for restoration and maintenance of normal volume status in patients with congestive symptoms or signs of elevated filling pressure. Okay. So sometimes, if the patient is in acute failure, as we have said in the previous class, okay, there will be congestion of the gastrointestinal tract also. So at that time, intravenous use of diuretics may be necessary to relieve the symptoms acutely. Okay, so if the patient still has persistent fluid retention with use of high dose of loop diuretics, okay, additional of thiazides or metolazone should be added to the loop diuretics. But whenever you are using the diuretics, okay, you have to be very careful regarding the adverse effects like electrolyte and volume depletion. I mean, this hyponatremia, hypokalemia, okay, and there can be worsening azotemia as well. The other group of drug that can be used is ACE inhibitors. Okay, should be used in symptomatic and asymptomatic patient with depressive sexual patterns. So ACE inhibitors and ARBs, these are the drugs which prevents remodeling. Okay, so it has to be used in all the patients with NYHA functional 1 to 4. Okay, ACE inhibitors, it stabilizes LV remodeling, improves symptoms, reduces hospitalization, and prolongs life. Okay, so whenever you are giving, it should be initiated in a very low dose, and the dose should be gradually increased. And you have to be very careful regarding the adverse drug reaction. Like, for example, the patient may have decrease in blood pressure. Okay, there can be hypertension, mild azotemia is common, and since this has property of potassium retention, okay, so it has to be used very cautiously if the patient is also using potassium sparing diuretics. Okay, and sometimes there can be adverse drug reaction related to kinin production. Okay, so there can be non-productive cough in around 10 to 15% of the patient, and angioedema in around 1% of the patient. And if a patient who are using ACE inhibitors, they are having these uh, side effects because of kinin production. Okay, the other drug that can be used in substitute of these ACE inhibitors are ARBs. Okay, so these are the drugs which are well tolerated, who are intolerant to ACE inhibitors. Okay, so some clinical trials even demonstrate the therapeutic benefit from addition of ARB to ACE inhibitor in a patient with chronic heart failure. But generally, ACE inhibitor and ARB both are not given because both of them cause hyperkalemia. Okay, so adverse drug reaction, there can be symptomatic hypertension, azotemia, and hyperkalemia. The other group of drug includes beta blockers. Okay, so these drugs interfere with the harmful effects of sustained activation of the adrenergic system by competitively antagonizing one or more of the adrenergic receptors, alpha 1, beta 1, and beta 2. Okay, and when they are given along with ACE inhibitors, they reverse the process of LV remodeling, improves the symptom in the patient, prevents hospitalization, and prolongs the life. Okay, and whenever we are giving this beta blockers in a patient who has acute left heart failure, okay, we have to um, start the dose of the beta blockers in very low doses, and no more rapidly than 2 weeks intervals should be kept in order to titrate the dose. Start with a very low dose, you increase the dose every 2 weekly only, because initiation or increasing the dose may worsen fluid retention. Okay, so it is generally as a consequence of the withdrawal of adrenergic support to the heart and the circulation. Okay, so it is better to optimize the dose of diuretic before starting beta blocker. Okay, so since it has fluid retaining property, okay, so it is generally advised to increase the dose of diuretics before starting beta blockers. Okay, so as we have said, there occurs the fluid retention. So it is more likely to occur within 3 to 5 days of initiation of therapy. Okay. So increased fluid retention usually can be managed by increasing the dose of diuretics, as we have already said, in some patients, and reduction of the dose of beta blockers is if required. Okay, so you start it with the low dose, you check for around 5 to 6 days. Okay, whether there is fluid retention or not. If there is fluid retention, you increase the dose of diuretics. If even if the if even after the increasing the dose of diuretics, if the patient still has um, fluid retention, the other way to treat is to just to decrease the dose of beta blockers. Okay, you have to be careful regarding the adverse drug reaction. It can cause fluid retention, symptomatic hypotension, and bradycardia, but around 80% of the patient they tolerate this beta blocker quite well. Okay, so other group of drug, aldosterone antagonists. These are the potassium-sparing diuretics. Okay, that affects the aldosterone, spironolactone, and eplerenone. These are the drugs that are in use. Okay, so these are the drugs that are recommended for patients which are in NYHA function class 4 or class 3, who are previously in class were in class 4, with a decreased ejection fraction, and who are having symptoms even after getting standard treatment with ACE inhibitors, ARBs, diuretics, and beta blockers. Okay, so this is for the add-on drug if the patient is in energy function class 3 or 4, and if the ejection fraction is less than 35%. Okay, so the adverse drug reaction that can be there in a patient who are using the spironolactone are life-threatening hyperkalemia, and it's not recommended in patient who has serum creatinine of more than 2.5 mg per deciliter. And since the patient who are using spironolactone, they may have painful gynecomastia. Okay, so it generally develops in around 10 to 15% of the patient. So if later on, it is the good substitute. Okay, so digoxin, this was a drug that was very much in use initially in case of heart failure, but it is generally recommended nowadays if the patient has symptomatic left ventricular systolic dysfunction with atrial fibrillation. Okay, and who have signs and symptoms of heart failure while receiving standard therapy with ACE inhibitors, ARBs, beta blockers, and spironolactone. So the therapy with this digoxin is commonly initiated and maintained at the dose of 0.125 to 0.25 mg per daily, and we are not using higher doses. Okay, so these are less beneficial. Now, this is the other drug that has been introduced. Okay, so this is the mm, neprilysin inhibitor. Okay, so there is only one drug that is sacubitril that is included in this group. Okay, so it is responsible for breakdown of endogenous diuretics at atrial natriuretic peptide and brain natriuretic peptide. Okay, so if they are used in combination with ARVs, mainly valsartan, okay, studies has been done with valsartan. It has been shown to produce additional symptomatic and mortality benefit over use of ACE inhibitors, uh, isolated ACE inhibitors. Okay, so this is the drug that is used for treatment of resistant heart failure. That means you have given the standard treatment with ACE inhibitors, ARBs, beta blockers, diuretics, patients still remains symptomatic, then this is the new drug that has been introduced. Okay, so ivabatrin, it acts on the SA node, okay, resulting in reduction of the heart rate. It has shown to reduce the hospital admission as well as mortality rate in patient with heart failure due to moderate to severe left ventricular systolic impairment. Okay, so the effect, it is more marked when the patient has higher heart rate over 77 per minute. Okay, so it is basically suited for the patient who cannot take beta blocker or whose heart rate still remains high despite use of optimum dose of beta blockers. Okay, now prevention of complications. Now we know about the complications of this heart failure. Okay, so it can be electrolyte imbalance, it can be thromboembolic phenomena, different cardiac arrhythmias, okay, sudden cardiac death. But there are some interventions that can be carried out in order to prevent the complications. Okay, like use of anticoagulation and antiplatelet if there is chances of thromboembolic phenomena. So anticoagulants and antiplatelets are used in a patient with heart failure who have increased risk for atrial and venous thromboembolic event. Okay, and patient who has depressed ejection fraction, like if the ejection fraction it is less than 40%. Okay, so it helps in stasis of the blood within the dilated chambers, which increase the risk of thromboembolism. So it is generally advised in a patient who have depressed ejection fraction as well. Okay, so warfarin, it is the drug that is recommended for these patients. Okay, so the heart failure or so it is this warfarin, it is recommended for all the patient with heart failure or chronic or paroxysmal atrial fibrillation. Okay, so if the patient has history of systemic or pulmonary embolism including stroke and transient ischemic attack. Okay, and if the patient has ischemic cardiomyopathy, whether the patient is symptomatic or not, if the patient has ischemic cardiomyopathy, then warfarin has to be used. And if the patient has documented recent large anterior MI or recent MI with documented left ventricular thrombus. Okay, so aspirin is recommended in heart failure patient with ischemic heart disease for the prevention of myocardial infarction and death, and generally lower dose of aspirin is preferable. Um, okay, and the other complication, as we know, is cardiac arrhythmia. Okay, and the most common arrhythmia that can be there is atrial fibrillation, which accounts for around 15 to 30% of the patients, and it is one of the important cause of cardiac decompensation as well. Again, for the patient who has atrial fibrillation secondary to heart failure, okay, amiodarone, it is the preferred drug for restoring and maintaining sinus rhythm, and it may work as the electrical cardioversion in patient with heart failure. So you have to be very careful whenever you are giving it along with digoxin, because amiodarone increases the level of digoxin, and you have to be very careful when you are giving it along with warfarin, because it prolongs the INR in these patients who are taking warfarin. Okay, so you have to be careful regarding the adverse drug reaction. There can be thyroid dysfunction, either hypothyroidism, pulmonary fibrosis, hepatitis. Okay, but whenever they are given in lower dose of around 100 to 200 mg per day. Okay, so the risk of these adverse drug reaction, they are lowered. Okay, so it has to be given at the dose of 100 to 200 mg per day to reduce the risk of adverse events. Okay, so now regarding the cardiac intervention. Okay, so with the standard drug therapy and the addition of other medicine also, okay, if the patient still persists to have symptom, there is indication of cardiac intervention. The first thing that can be done is insertion of implantable cardiac defibrillators. Okay, so effective in treating ventricular tachycardia or ventricular fibrillation in patient with heart failure with recurrent arrhythmias or cardiac syncope. Okay, so this is generally indicated in patients who have heart failure, who presents with recurrent episodes of ventricular arrhythmias, ventricular fibrillation and tachycardia, and cardiac syncope. Okay, so it is also considered for the patient with NIHA functional class 2 to 3 with depressed ejection fraction who are already on background therapy, including ACE inhibitor, beta blockers, and aldosterone antagonists. Okay, so if the patient has depressed ejection fraction, if the patient are in NOIHF function class 2 to 3, even with standard medical therapy for heart failure, then this may be the indication for ICD. The other cardiac intervention that can be done is cardiac resynchronization therapy, where there will be biventricular pacing will be done, which stimulates both the ventricle nearly simultaneously, which improves the coordination of the ventricular contraction, reducing the severity of mitral regurgitation. Okay, so it is generally recommended for patient in sinus rhythm with ejection fraction of less than 35% and QRS complex of more than 120 milliseconds for those who have symptomatic um, heart failure despite optimal medical therapy. Okay, so this was regarding management of heart failure. Okay, so we'll be talking about shock now, shortly regarding shock. Okay, so I've tried to very concisely mention about everything in shock that is important for you. Okay, so if we go individually, it will take very long time because we have to talk about hypovolemic shock, cardiogenic shock, obstructive shock, septic shock, anaphylactic neurogenic. Okay, so with the management and pathophysiology for each one of them, it will be very long, but whatever is required for you, I've mentioned it. Okay, so we'll be starting with shock. Okay, so it is defined as a condition in which the level of oxygen delivery fails to meet the metabolic requirement of the. Okay, so there will be imbalance between the oxygen demand and the supply to the tissues. Okay, so the causes may be low flow due to low flow or reduced stroke volume or due to low peripheral arterial resistance because of vasodilatation. So low stroke volume, it may be because of hypovolemia. Okay, so any condition provoking a major reduction in blood volume, that may be internal or external hemorrhage, severe burn, fluid and water depletion. Okay, so hypovolemic shock, it may be as a result of hemorrhage, okay, road traffic accidents. It may be because of excessive diarrhea, excessive vomiting, leading to salt and water depletion, and it may be as a result of severe burn. Cardiogenic shock. Okay, so it is generally because of severe mechanical impairment, like in cases of acute myocardial infarction, acute mitral regurgitation. Okay, so these patients may land up in cardiogenic shock or acute left heart failure. Okay, obstructive shock. Okay, so it is because of obstruction to the blood flow around the circulation, like in cases of pulmonary embolism, cardiac tamponade, and tension pneumothorax. Okay, this results in obstructive shock. And shock due to vasodilatation, septic shock, or systemic inflammatory response syndrome. Okay, infection or other causes of systemic inflammatory response that produces widespread endothelial damage with vasodilatation, AV shunting, microvascular occlusion, capillary leak, and tissue edema. And the other type of shock is anaphylactic shock, which is also because of vasodilatation. It is generally because of inappropriate vasodilatation triggered by any allergen, okay, like bee sting, wasp bite. Okay, and it is often associated with endothelial destruction and capillary leakage. And the other one is neurogenic shock, which is generally caused by major brain or spinal injury, which disrupts the brain's stem and neurogenic vasomotor control. So the clinical features, it generally depends on the primary pathophysiological abnormalities. Okay, like in cases of hypovolemic cardiogenic and um, uh, obstructive shock, it is because of low perfusion. So there will be circulatory failure, and they will present with a classical image of shock. Like the patient will have very cold peripheries, the peripheral pulses, it will be reduced in amplitude, and sometimes it may be absent. Okay, or very feeble. Okay, weak central pulses will be there, and there will be evidence of low cardiac output. Okay, the blood pressure, it will be low, the urine output, it will be low, the patient will have tachycardia. Okay, and if the patient has septic shock or anaphylactic shock, the patient will have warm peripheries, the patient will have bounding pulse. Okay, so everything will be different if the patient has septic shock or anaphylactic shock. And features of high cardiac output will be there. In early stage, peripheral vasodilatation result in low blood diastolic blood pressure, but since the ventricular afterload is reduced, stroke volume and since the systolic blood pressure are maintained, and patient are usually warm periphery. Okay, and in more advanced septic or anaphylactic shock, systolic blood pressure falls and peripheral becomes cool. Okay, so initially it will be warm peripheries, but afterward it may be cold. Okay, and it is usually because of hypovolemia associated with capillary leakage, and this will respond to fluid resuscitation. Okay, initially in early stage there will be warm peripheries, but in late stage, okay, so if there is capillary leakage, then there will be cold peripheries. And in cases of neurogenic shock, okay, so it generally results in vasodilated hypotension with a paradoxical slow heart. The patient will have hypotension, but patient will have slow heart rate instead of tachycardia. And all forms of shock require early identification and treatment of the condition, because if inadequate regional tissue perfusion occurs and if the tissue deoxygenation persists, okay, and they land up in multi-organ failure. So the prognosis, if the precipitating cause and accompanying circulatory failure are dealt with properly before significant organ failure occurs, prognosis is good. But in cases of late shock, okay, so it may deteriorate the organ failure, leading to multi-organ failure. Okay, so the mortality of multi-organ failure is high and increases with number of organ that has failed and duration of organ failure and patient's age. Okay, like for example, there can be renal failure, there can be respiratory failure. Okay, and as the number of organs are involved, the mortality, the prognosis, it becomes worse and worse. Okay, failure of three, four or more organ is associated with mortality of more than 80%. Okay, now since we were talking about this heart failure, okay, I want to mention again something about the cardiogenic and shock and pulmonary edema. Okay, so as we have already said, it is the medical emergency. So the pulmonary edema, if the patient has, okay, there will be some cardiac abnormalities that leads to increase in the pulmonary venous pressure, which shifts the balance between the capillary and the interstitium, resulting in capillary leakage, leading to interstitial and alveolar edema. Okay, so there will be interstitial as well as alveolar edema because of capillary leakage. The most important causes are acute myocardial infarction, which leads to left ventricular failure, which may be because of ventricular septal rupture, papillary muscle or chordal rupture, okay, ventricular free wall rupture, okay. So as a complication of acute myocardial infarction, it may occur, or it may occur in a patient who has post-cardiac arrest, post-cardiotomy, in patient with in-stage cardiomyopathy, sometimes in cases of pulmonary embolism, and sometimes in cases of valvular heart diseases and hypertrophic cardiomyopathies. Okay, so these are the common causes. Clinical findings of pulmonary edema. Okay, the patient may have chest pain and dyspnea. The patient will be very pale. Okay, the patient will be very apprehensive and diaphoretic. Okay, diaphoretic means the patient will sweat a lot. Alimentation may be altered, and somnolence, confusion, agitation may also be there. Okay, and when we check the pulse, it will be very rapid and it may be very weak. It may range from 90 to 100 beats per minute, and severe bradycardia may be there if the patient has high degree AV block. And when we check the blood pressure, the systolic blood pressure will be reduced. It will be more than 90 with narrow pulse pressure. Okay, so the pulse pressure, as you know, is the difference between the systolic and the diastolic blood pressure. Okay, it will be less than 30 millimeter of mercury. But occasionally, blood pressure may be maintained by very high systemic vascular resistance. And along with that, the patient may also have chine, stroke, respiration, tachypnea, JBP distension, or increase in JBP. Okay. When we do the precordial examination, the precordium, it may be quiet with weak and with apical impulse. S1 may be very soft. There can be S3 gallop. Okay, so this S3 gallop, regarding this gallop, we have already discussed yesterday. Okay, and there may be evidence of this severe mitral regurgitation, ventricular septal rupture. This is generally characterized by pansystolic normal. Okay, and when we are doing the respiratory system examination, there may be crepitations or rales which are audible in patient who have left ventricular failure causing cardiogenic shock. Okay, and oliguria is also common in these patients. And for the laboratory findings, okay, total count has to be done, differential count, renal function, and liver function test has to be done to see for elevated hepatic transaminases. It is because of liver hypoperfusion. And we have to do arterial blood gas analysis to see for the anion gap acidosis. Okay, and there can be increase in the lactic acid level as well. And we have to see for different cardiac biomarkers. Okay, creatine phosphokinase MB fraction, troponin I, and troponin T. Other evidences can be seen to check for the cause of cardiogenic shock, like ECG. Okay, so all these we have already discussed in when we are discussing heart failure. Okay, so echocardiography, chest X-ray, pulmonary artery catheterization, coronary angiography. Okay, so the treatment of acute pulmonary edema, it generally depends on the cause. Okay, so what is the cause for acute pulmonary edema? Is it the valvular heart disease? Is it the myocardial infarction? Okay, measures applied to support circulation and gas exchange, and we have to be careful regarding the aggravating factors. Okay, you have to treat the aggravating factors as well, to treat the infection if the patient has, if you have to check the blood, the hemoglobin level. If the patient has anemia, you have to give transfusion. You have to check whether the patient is in renal failure. Okay, so for the treatment, support oxygenation and ventilation. Okay, so with this we have already discussed. Okay, oxygen therapy, positive pressure ventilation, physical methods by keeping the patient in propped up position with leg dragging alongside of the bed. Okay, so these are the drugs that are used for acute. So this we have already discussed when we discuss about acute left heart failure. Okay, so the diuretics, with diuretics like furosemide, torsemide, they can be used and they are effective. Okay, so they have the vasodilator property along with diuresis. Okay, so the dose, it is generally around 1 mg per kg. Okay, so the other drug that has to be used is nitrates, sublingual nitroglycerin has to be given. And if the patient has persistent pulmonary edema in absence of hypertension, okay, IV nitroglycerin, it has to be started at the dose of 5 to 10 microgram per minute. Okay. And there is a role of morphine as well. It is generally to relieve dyspnea and anxiety in a patient who are in acute pulmonary edema. Okay. So it causes transient venodilatation, reducing the preload in the failing heart. And there is role of ACE inhibitors as well. It helps in optimizing the preload, decreasing the afterload, and it is generally recommended in patients who are hypertensive. Okay, and the dose, it should be started in a very low dose and it should be gradually increased. There may be role of inotropic drugs like dopamine, dobutamine. Okay, so it should be used in infusion in a patient who are hypertensive. Okay, and there may be role of intra aortic counterpulsation. It is generally to stabilize pulmonary edema due to severe mitral regurgitation and ventricular septal rupture. Okay, so that's all
ম্যাম
regarding.
কি হতো ইন্ট্রায়োটিক পানি কোচে